Yes.
Thank you. Dr. Gillon, I want to move on to look at the broader picture of donor selection in Scotland. In 1985, one of the first tasks you said you were given by Professor Cash was to visit each of the 5 centres and discuss their selection processes. Is that right?
That's right.
Did Professor Cash explain to you what his particular reasons for the review were?
No, in a word. I think it was along the lines of, everybody seems to be doing something a wee bit different. We should really have a unified view of this. Can you go around and chat to your donor consultant colleagues and come up with some suggestions?
You produced a report in relation to that. If we could have PRSE 40997. We can see at the top of the page the heading background. The guidelines on the care and selection of blood donors issued by the NBTS have been felt in the SNBTS to require adaptation. The National Medical Director and the Regional Directors therefore asked me to prepare a report comparing donor selection practices in the 5 Scottish regions in an attempt to assess the significance of the existing differences in practice between the SNBTS centres and the NBTS guidelines. You then set out your method and your results. And we can see as we go through the document headings where you've identified what you describe as the most obvious areas of disagreement, in no particular order. Frequency of call-up, then over the page. I'm very sorry, sir, for some reason, the rest of the document isn't available for the screen, but I can simply pick up what I need to orally. So the headings of the matters, the most obvious areas of disagreement were frequency of call-up, anemia, medication, allergy, diabetes, epilepsy, infectious mononucleosis, cancer, malaria, thyroid disease, hypertension, gastrectomy, dental treatment and tattooing. There doesn't appear to be anything in your report in relation to any differences in practice concerning hepatitis or jaundice. Does that accord with your recollection that there wasn't any particular matters of disagreement on those issues?
Yes, that's right. I mean, I think those issues had been discussed by the directors at their meetings, and I'm pretty sure they were all dealt with in the same way, in a very common way.
And the same in relation to HIV and AIDS?
Yes, indeed.
You've referred in that paragraph background that there was felt to be a need to require adaptation of the guidelines. Why was that? Why was there felt to be a need for local variation?
I think it was to avoid donors being confused, for one thing. You could have a donor who's accepted in one region, and as we were talking about this morning, then going to give blood in a different adjoining region, sometimes even maybe just the town next door, and discovering that they were not allowed to donate for a reason that would have been acceptable previously in the other region.
Sorry, Dr. Gillon, perhaps my question wasn't quite clear. When you first undertook this review, it was noted that there were differences. In your recommendations, your recommendation was that there shouldn't be any differences in approach, there should be consistency in approach. Can we take the first point first? Was there ever any explanation to you of why different regions felt that they should be different to each other?
No, but of course, as I went round chatting to my colleagues, they would defend the practices they had in their particular region on whatever grounds seemed appropriate to them. I noted that, compared it to what we did, and drew up this report. very often they were relatively trivial differences. Like in one region you might be deferred for a month, in the other region you'd be deferred for six weeks, for instance. Something like that.
Your
So a lot of it was about trying to iron out unjustifiable, relatively trivial differences.
Your recommendation on the final page of the document, for those who can see it on relativity, the final page of the document recommends a comprehensive set of guidelines. And you say this: any such document would naturally have to be flexible enough to take account of local factors and also be designed in a way which allows easy updating. What were you contemplating when you talked about the guidelines needing to be flexible enough to take account of local factors?
I have no idea. I really can't remember.
Before we look at the guidelines, I just want to ask you to take a step back from that exercise of reviewing the different practices across the 5 regions. Just before you did this review, you'd spent 3 months in the US. Was there any striking differences for you between the approach that you were seeing when you undertook that review compared to what you'd seen in the US?
Not really. I think one of the things that struck me was how similar the system was in Kansas City, which was there were various different organizations who organized the donor service in the States, the main one being the American Red Cross. But there were other organizations who did it, and the one that was in Kansas City was the Community Blood Banks. It was an organization of community blood banks, which was nationwide, but numerically, in terms of providing blood, not huge. And it had much the same feel as the Edinburgh Centre. It was much the same sort of size, with the same kind of setup, with a donor centre and community sessions in schools and in hospitals, actually, which is one thing we did little or nothing of, apart from in the donor centre. And it really was strikingly similar. I doubt if it was the same all across the States, but it just so happened that Kansas City felt a bit like home to me in a way.
And in terms of the donor selection processes they were following in that particular location, again, was there any particular difference you noticed as between that and the review you'd undertaken?
There really wasn't, except that they did not have doctors going to sessions. Everything was done by nurses, which is something that eventually we came round to in the 1990s. But apart from that, the processes, the procedures were all very similar. One big difference was that the premises that were available to them were vast by our standards, school halls and church halls that were easily big enough to separate all the various bits into, a waiting area, clerking area, somewhere you could chat in private to a donor, and that seemed quite luxurious to me.
And just to be totally clear, what you're discussing in relation to the States was a centre where donors were volunteers.
They were entirely volunteer donors.
Having completed your review in 1985, you then worked with others to produce a set of comprehensive guidelines that were published in 1988. Could we have that on the screen? PRSE 301327, please. We can see their guidance for the selection of blood donors, and the date is given November 1988. What was the reason for the time period that it took for the guidelines to be produced?
It's not quite as bad as it looks, in the sense that I was appointed in April 1985 1985. So I got started late in 85 and had to visit all 4 of the other centres and put it all together and present it to the coordinating group. I think it was towards the end of 86. So it was the end of 86, and then I think presented, I can't remember when I presented it to Professor Cash, but I was working on it with Dr. Eva Brooks, who was based in Dundee, and it was not an easy task. There was a lot of discussion went on with people in the various regions. People were very sensitive about having their authority taken away, I think, to some extent. They were guarded when I first went to see them and talked to them about it. Sometimes quite reluctant to engage. And Eva Brooks was very useful in that respect. She was highly respected. She had been there for a long time. She was very diplomatic, and Eva and I put this together as fast as we could in the circumstances, and there was no particular reason for delay. It wasn't that anybody was obstructing it or there was any particular problem. It just took a long time.
If we turn to the next page, page 2, please, we can see in the guidelines the heading AIDS, and we see standard operating procedures with regard to the AIDS selection criteria must be rigidly adhered to. In the case of uncertainty or any query from the donor, the doctor must be consulted. And then turn on to page 11, please. Hepatitis at the bottom of the page. Childhood jaundice stroke hepatitis with full recovery, accept. Jaundice, hepatitis, hepatitis B, consult sister or doctor. Note for sister or doctor. Defer and obtain more information from GP. May be acceptable 1 year after full recovery. History of hepatitis B usually do bars. Refer to centre. And then hepatitis contact, defer for 6 months after close contact, e.g. live together using same towels, crockery, etc. Then if we go on to page 31, please. We see the 1987 version of the AIDS document. I've picked out from the guidelines the hepatitis and AIDS points. Did these guidelines that you produced require any changes to the practice in Edinburgh so that you were compliant with the guidelines?
No, not as far as I can remember. And in fact, I don't think anyone would have had to change what they were doing very much, because these are very much agreed at national level, possibly even UK level. Then
in 1992, you introduced in Edinburgh personal donor interviews, and that was then rolled out nationally. Can you talk us through, first of all, how those personal donor interviews operated?
They depended entirely on having very private areas designated, and we had sort of booths curtained off and a distance away from all of the other congregations of donors. So a nurse or doctor would sit down with the donor and would directly ask the donor, have you at any time had sex with another man? Have you visited Africa? Would read exactly what was on the list of questions. And any discussion about it would be entirely private. And that was how we did it. It was as simple as that. I referred earlier to the need for the person doing the interviewing to use a neutral tone and matter-of-fact sort of delivery, and I think that was really quite crucial to get donors to engage. But they found that when you did that, donors would really quite readily tell them if anything was on their mind. And of course, it wouldn't be everybody. There would be people who would not respond to that.
Were those interviews just for new donors or for returning donors as well?
They were just for new donors.
Why was that? Why were they not introduced for returning donors?
The returning donors they had a slightly different form, and there would be instructions on the form and making it clear that they had to pay attention to the AIDS criteria and the fact that they might not be the same as they thought they were from the previous visit, and they had to sign that form. We felt that in the case of regular donors, for a start, there was a practical problem. If you had to do that, it would take an awful long time and could really be quite disruptive to sessions. But also, we felt it was unnecessary, or at least of slightly lesser importance than dealing with the new donors. And I think there was a lot of justification in that. When you look at the number of HIV positive tests we had, which weren't enormous, but it was almost always new donors.
They were introduced in 1992. Why were they introduced? A similar question to I asked you earlier about the flashcards. What was it that triggered the introduction of these interviews?
It had been brewing for a long time, and we'd had discussions with people in America who'd been doing this. And there was a lady who was, I think not a doctor, but a donor organizer somewhere in the East Coast in America called Donna Mayo, who had published in this subject. And Mary Thornton had had contacts with her. Mary Thornton was by then the National Donor Services Manager. And at a symposium, I think in the College of Surgeons in Edinburgh, we had Donna Mayo come across and give us a talk on her experiences. That was, I can't remember exactly actually. It had been brewing for a while, so we'd been interested through the late 80s and finding it very difficult in terms of resources, in terms of making space in the sessions. But we were very keen to get it up and running, and that's why we set up this symposium where it was discussed and agreed, and went to the national directors who gave us the go-ahead to get on with it and do it. We needed funds for it for a start, to some extent. And I would rather it had happened 5 years earlier, say, or 6 years earlier, but for very practical reasons, that's as soon as we could get it moving.
And when you say those practical reasons, was it a resource question, or even with resources it wouldn't have been possible?
Probably the latter. There was a resource problem because it meant extra time, which meant extra staff, as well as extra equipment. Yes, it was partly practical, and it was about staff training as well. That took a long time, and we were forever ramping up what we were asking staff to do at training sessions. So we'd had it in our sights for a long time, but when I look back, I was, quite frankly, not having thought about it for a long time, I was a little bit shocked myself to see that it was 1982 before we did it. But it was 1992, It was 1996 before the other regions managed to implement it.
That was what I wanted to discuss with you, Dr. Gillon. You've said in your statement it was over the following 5 years that the personal interviews were extended across Scotland. What was your involvement in the national rollout of personal donor interviews?
Not much. By then we had the donor consultants group, which met regularly, chaired by George Gallia, whom we heard from him, I think, quite recently. And it was a regular subject to be discussed at the donor consultants group. I can't remember how often we met. I think theoretically quarterly. But it took a long time. And again, I don't have a very easy explanation for that. I think there might have been some reluctance. It took a lot of organising. It took a bit of extra money. That was the reality.
In 1996, you were tasked with leading an initiative to bring the donor service practice in Glasgow and Edinburgh into closer alignment. What were the particular differences that you found between the two centres?
There was a bit of a culture difference on the sessions. I've mentioned a practical issue, which was the way they recorded signatures. And there was just this feeling that they did a lot that was different from everybody else in Scotland. And they developed their own ways of doing things. There was a feeling of negativity about the way the donor service worked in Glasgow at that time. And I think it felt a bit Cinderella for some reason. It took a wee while to get good engagement with the senior staff in the donor service there and get them to start challenging the way they did things. I think little had changed in Glasgow over quite a number of years. They always seemed a bit reluctant and resistant to new ideas, while not really coming up with anything very much themselves. And there was just a feeling of negativity about the place, and I think that was what we tried to tackle, and I hope successfully. But that would be for others to judge.
When you say they were resistant to new ideas, did that include things like the personal donor interviews, or are you referring to other things?
Yes, I think it did. I think they really didn't get it, in a sense that we've always done it this way, was the kind of attitude that seemed to be prevalent there. And I think I guess it stemmed from the top, and there was always a feeling that Glasgow wanted to do it their own way. They had some justification for that, in that they were by far the biggest region. They had some particular problems, like not a lot of their sessions, but they had to organise and run sessions in the Western Isles, for instance, in Dumfries and Galloway. So they had a huge geographical area with very difficult logistics. And that kind of set them apart. The other thing that set Glasgow apart was that they did not have any blood banking service. So although they eventually became located in Gap Naval Hospital, they had no responsibility for clinical transfusion practice. And these things, I think, just made them feel that they were different and a bit resistant to what came out of the centres in the East. I don't think I could make it more specific than that. It was a culture difference, really.
Dr. Gillon, I want to move on to the HIV screening tests. While you were in the States, you spent some time with Dr. Tetmeyer, who was at that time working on HIV testing.
That's right.
But it's right, isn't it, that when you came back to the UK, you weren't particularly involved in the introduction of HIV screening tests?
Not in actual practical sense, no.
When you first joined the SEBTS, your work, as I understand it, was concerned with discussing with those donors who tested positive and undertaking the look-back processes. Is that right?
Yes.
First of all, then, in relation to donors who had tested positive in the HIV screening, can you tell us what happened then with that donor?
The donor would receive a letter from me advising them that one of the tests had shown I can't remember the exact wording, but a test result required further investigation, and asking them to make an appointment to come and see me. And I would, as we all would in Scotland, we made ourselves available very quickly for that purpose, and the phone call inevitably came, usually the following day, as soon as the letter arrived. And we would attempt to see the donor at the very earliest possible opportunity. And that was when we did what was referred to across the transfusion community, across America, everywhere, as counselling, which was basically telling them what was going on. And almost invariably it became obvious quite early in the discussion that the problem had an obvious cause. And that's where you get into something that could appropriately be regarded as counselling, when it was acknowledged that this was likely to be a true result and that something needed to be done about it and what that might be. We also took another sample and repeated the testing, which is very important, and usually arranged to see the person again quite quickly, or if necessary, referred them on quite quickly, for instance, to the special clinics that have been set up to deal with anybody concerned about the possibility of having AIDS, for instance.
What was the purpose of seeing the person a second time?
It was partly to give them the results of the second test rather than just sending them a letter. It was to pursue any issues that they had or wanted any more clarity about, and simply assessing them and giving them some support and the feeling that they were not just being shoved out the door and forgotten about, and that we really took seriously a responsibility to make sure that they got proper assessment, proper treatment and support.
If the donor who tested positive had donated previously, it was then your responsibility to trace those donations, is that right?
That's right.
How did you go about that?
What would happen would be that from the testing lab, I would get not only the results of the current donation, but they would identify the previous stored serum samples and thaw them out and test them, which would give us a guide as to possibly a time when the donor had seroconverted. If there were, if you had a sequence of samples, then you could go back until you got negative samples, and you could usually tie that up with the donor's description of when they thought they might have been infected.
And those stored samples were the samples we discussed earlier that had been held since 1984?
That's correct. So in the case of HIV, it didn't go back very far, but we did have some, yes.
Once you'd identified the samples, it's right, isn't it, that you then traced through to identify any recipients of infected blood and blood components?
Yes. What I would then get from the lab would be a list of the previous donations, what components had been produced. If plasma had gone to PFC, that would have been notified to PFC immediately. And then the fate of these various components would be explored. We would know to which blood banks the components had gone in the region or elsewhere. And we would then contact the relevant hospital blood banks to try to establish the identity of the recipient for each and every component.
And generally, you would end up seeing the recipients rather than their GP or consultant?
As a rule, yes. Occasionally, particularly if it was, say, up in the middle of Fife or in the borders or something, the patient, the donor, the patient, the recipient would ask if they could be seen locally, and that would be arranged. That would be easy enough. Very occasionally, the clinician who had been in charge at the time of the recipient's transfusion would offer to do the initial follow-up. And that would be the case, particularly if they had an ongoing relationship with the patient. More usually, they would say that they didn't feel adequately informed to do that, and in which case we would usually go to the GP first. GPs would almost invariably say they didn't know enough about it, but occasionally they would say they would tackle it in the first instance because they knew the patient, and I would offer to see the patient if they wanted.
In terms of undertaking that tracing and identifying recipients of donations, what problems, if any, did you face in that task?
The biggest problem by far was missing hospital records or failure to record the eventual fate of a blood component. And that could be for all sorts of reasons. From records being lost or destroyed. Some hospitals had a relatively short period of storage for records. Most didn't. By then, I think most would keep at least 5 years worth. But all sorts of administrative problems like that and simple practical problems made it impossible to trace quite a substantial percentage of the components.
If you knew that a donor had donated elsewhere outside of the SEBTS region, what process did you then follow in terms of look back?
I would then have written to the equivalent doctor to me in that region, and they would have started the same process.
Was there any way for you to check whether a donor had donated elsewhere if they didn't tell you?
No. No, I don't think there was, until the national computer system became active in 96-ish or something like that.
So before 1996, you were reliant on a donor saying, remembering, having it written on their donor card that they donated outside of SEBTS.
Yes, exactly.
Before we move on to hepatitis C, I just want to deal with autologous transfusions. First of all, can you explain in terms that a layman would understand what an autologous transfusion is?
There are various types of autologous transfusion, but usually the basic type is when a patient is scheduled for surgery, which is likely to result in the need for transfusion, and the patient is otherwise fit and well, and by other criteria would meet the requirements for blood donation. In other words, they would have to have an adequate hemoglobin level and be fit in terms of cardiovascular fitness, for instance, such that taking a unit of blood from them would cause them no harm. They would have to be committed and keen to take part in the procedure, which entailed them attending in the weeks prior to their operation to give however many units of blood were considered necessary, up to a maximum of 3 or 4, depending on the timing. Relatively rare it was that you would take 3 or 4 donations. More often it would be 1 or 2. And the sort of operation was very important. It was most appropriate for hip replacements, for instance, where there was a more or less guaranteed need for a couple of pints of blood, where patients were often, in other respects, fit with no cardiovascular problems, although many did, dealing with an elderly population, obviously. And they had to be motivated. And one of the motivations was that when they were accepted onto the program, and this was spelled out in the literature, it more or less guaranteed that their operation would take place, because having done that, they donated a couple of pints of blood, which would have rendered them slightly anemic. The consultant would be under tremendous pressure to go ahead with that operation. So there was a positive benefit in that sense, in that very practical sense. But the real reason was to avoid using donor blood, obviously.
And the reason to pick it up at this point in our discussion, Dr. Gillon, is that you established the facilities for autologous transfusions at the SEBTS in 1987. And you think that SEBTS became the first centre in Scotland to have those facilities?
We were the first in Scotland, certainly. And, certainly one of the first in the UK in the transfusion services. There were haematologists who were attracted to the idea and carried it out in a single hospital setting in England. But I think in terms of the transfusion services, we were probably one of the first. Yeah.
So in 1987, what was your rationale for setting up the facilities?
I can't remember if I was approached by one of the surgeons or anaesthetists first, or whether it was my own initiative. But I did find the idea quite attractive. I was keen to have a go at it. And there was at least one anaesthetist and one orthopaedic surgeon who had expressed an interest. And I can't remember, at one point, we organised a meeting with the orthopaedic surgeons who actually operated in a completely separate hospital from the Royal Infirmary, although they all had a base in the Royal Infirmary. But a lot of their elective work was done at a separate hospital that only did orthopaedic work. And that was quite an attractive prospect because it was a relatively controlled environment with no acute admissions. So basically, if you were scheduled for an operation there, it was more or less guaranteed would take place. So we had a good setup for it. I guess it was something that I'd come across in America or in the American literature, as you do, and thought it was a good idea.
Was it a simple academic interest, or what was it that was particularly attractive to you about the use of autologous transfusions?
There was nothing personal to me about it, although various of the female members of my family had blood transfusions. So I was alert to the whole business of blood transfusion within the family, and was keen to minimise the risk, and not just for my own family, but for everybody else's as well.
So in setting it up in 1987, was it the potential for the transmission of infection that was in your mind as a particular benefit?
Yes. I mean, I think that was the driving force for it.
Could we have RCSE 603, please, Paul? We can see that this is a programme and outline of presentations from a meeting at the Royal College of Surgeons of Edinburgh in May 1989. And if we turn on to page 20, please. We have the synopsis of your paper, Dr. Gillon, on autologous transfusion. It sets out here the association of HIV transmission with blood transfusion has stimulated worldwide interest in autologous transfusions, the benefits of which for the patient include the avoidance of alloimmunisation and decreased risk of transfusion-transmissible infections, including HIV. Autologous transfusions also augment the blood supply, but carry the potential disadvantages of diminished patient safety if procedures are less rigorous than for homologous transfusion, and increased costs for transfusion services. You then set out 3 methods of autologous transfusion: preoperative hemodilution, pre-deposit liquid storage, and intraoperative blood salvage. And then your final paragraph reads, current information suggests that under optimal conditions, up to 10% of all transfusions could be autologous. Further clinical and cost-effectiveness studies are necessary. That figure of up to 10% of all transfusions that you've cited in the synopsis of your paper, is that something you still consider to be accurate?
No, it turned out not to be the case, and in fact, the first paragraph of that synopsis turned out to be more true than the last one, which is that it was not without risk in itself, the procedure, unless it was done very rigorously and very well controlled and supervised medically. There are real additional risks certainly in the pre-deposit type that we were discussing, where the patient gives, over a period of 3 or 4 weeks, gives up to 4 units of blood. A variety of things can go wrong there, depending on the setting. You have to have an absolutely watertight system for handling that blood, storing it, labelling it, ensuring that it's available on the day of the operation for the patient. It had to be cross-matched, again, with the patient, just to make sure there was no mix-up with the blood itself. And therefore, it was adding layers of complication to the transfusion process, which eventually, it became clear, did lead to some things going, I think, maybe not disastrously wrong, but wrong enough to be potentially dangerous. And I have to say, not in our experience. I think overall we dealt with something like about 200 patients in Edinburgh over the years. So it was never a very high volume issue, but it was relatively high risk. And the conclusion that we in Scotland finally arrived at was that, in fact, it should be reserved to very rare cases where there was a good reason for undertaking it, rather than as a routine procedure. And we in Edinburgh stopped doing it and agreed that if anyone, and usually the reason for doing it would be a patient who had heard about it, who knew about it, and was very keen to have it. So we agreed that Glasgow would take over responsibility for any pre-deposit autologous transfusions. And that would have been, I can't remember exactly when, late 1990s perhaps. And thereafter, it became a very infrequent procedure.
And as you say, your recollection is there were only about 200 people who took up the service across the years in any event. Why was that take-up relatively low?
It fluctuated. It depended hugely on the surgeon or an anaesthetist being an enthusiast. And it was often an anaesthetist, and they came and went. You know, they might be a young, ambitious anaesthetist who heard about this or saw it somewhere in training and decided they wanted to have a go at it. Because superficially, it's an attractive prospect that you avoid all sorts of problems if you don't have someone else's blood transfused into you, and you can guarantee that you get your own blood back. That's very tempting. And it's tempting for the anaesthetist, who would be the one who would be in the hot seat if anything went wrong with any sort of transfusion, that they would see it as kind of a safe option, but in fact it turned out to be just a more complicated option.
So I'm about to move on to hepatitis C as a topic, which obviously will take us longer than the next 10 minutes to lunch. I'm happy to start it, or we could take a slightly early lunch.
Well, we've only just
Yes.
recently come back from the break.
Apologies,
So let's go on for
Let's
the
start.
10 minutes and stick to the 1 o'clock time.
Can we start, Dr. Gillon, by just exploring your understanding of non-A, non-B hepatitis? When you joined the SEBTS, what was your understanding of the seriousness of non-A, non-B hepatitis in terms of morbidity?
I think in common with most of the profession at the time, I understood it to be a chronic but relatively benign form of liver disease. We didn't know what was causing it, of course. There was an awful lot of research going on at the time, including in the department in Edinburgh, to try to find a putative virus. But so in that sense, it was only known as hepatitis in the sense of being inflammation in the liver. There was no guarantee that we would ever find a causative agent, in spite of huge amounts of effort across the globe, really. People trying to find an antigen or an antibody, or an antigen and its relevant antibody in the blood of people with this chronic form of what was called hepatitis was not always proved in biopsy, and simply a disorder of liver function, a mild disorder of liver function is what it appeared to be. And that was my understanding from courses I had done. For instance, I'd been to a course at the Royal Free Hospital where the famous Sheila Sherlock operated and had written the famous textbook that described it as a chronic low-grade and essentially benign condition for quite a long time, I think.
The inquiries looked at a number of papers, including research that was undertaken by Professor Preston that showed that non-A, non-B could result in cirrhosis and significant progression of liver disease without any symptoms. Was that research that you were familiar with?
I certainly became familiar with it. I can't remember when he was publishing those data, based, I believe, on haemophiliac patients.
Yes, exactly.
Yeah. So that would probably be the early 1980s, I think. Yes. I was aware of that. Yes.
So in the early 1980s, was your understanding of non-A, non-B hepatitis that it was benign, or in light of the papers from Professor Preston and others, had you then come to the understanding of its seriousness?
Yes, I think once the information came out about the liver biopsies that were showing cirrhosis and patients becoming ill, I think the realization was that it could become a serious problem.
Could we turn to PRSE 304163, please, Paul? Could we go back to the first page, please? Do we have the rest of the document? So there's been another glitch with the documents. I will pick that up over lunchtime in relation to any further documents I'm going to.
Well, we can come back to this document, can we?
We're only missing page 1, and it just gives us the date, sir, so if you're content, I can
what is
continue.
the
The date of the document is the 3rd of March 1987, and it's a Scottish National Blood Transfusion Service directors meeting.
Yeah.
And the minutes indicate that Dr. Gillon attended for items 3B, 12 and item 4. Could we turn then to page 5 of the document? Dr. Gillon, I don't think you were in attendance for this part of the meeting, but I just want to refer to it to give some context to my other questions, if I may. There's a heading at the bottom of the page, surrogate testing for NANB. The UK Working Party on Transfusion-Associated Hepatitis had been reconvened to pursue the issue of implementing surrogate testing for non-A, non-B. A proposal for a study which would include the Glasgow and Edinburgh transfusion centres had been modified, and no Scottish centre was now being asked to participate. Then if we go over the page, so we've had further difficulties with the document. I think we'll need to come back to it after the break. Sorry, sir. Apologies, Dr. Gillon. We'll move on to a paper that you published in 1988. If we could have PRSE 302655, please. So I am sorry, we checked the documents before we started this morning. They were all present on the system, but again, we've got the same problem of
Well, it sounds like a system fault, which we'd better get ironed out,
I
because
think we had.
otherwise we are wasting Dr. Gillon's time.
We are.
So let's take a break now, Dr. Gillon, see if we can get this sorted, and come back at 5 to 2, if that's okay. So time for a lunch break, back at 5 to 2.
Thank you.